We are live, doctors. You can start the session.
Yeah. At the outset, I would like to welcome all the attendees, all the faculty, as well as the whole team YOSI here for this wonderful initiative by the Journal Club team and team YOSI. And before we start, a few words on the YOSI Journal Club publish or perish a call to action. So this is our current team for the year 2024 to 26, led by dynamic Divakant sir, our president, and Nilesh, our secretary. And these are the dynamic executives of team YOSI. And we started this journal club by Sonal Kalia ma'am 3-4 years back. Wanted to keep the concept of a YO, a fellow, a PG, be it first year, second year, and third year. So the framework of the journal club was to cater all the young ophthalmologists of different categories and assessing research literature, be it definition of problem or the research question or defining the variables, dissecting the paper completely in situ with analysis, interpretation, and the MAARIE format. And that was a format that was devised by the previous team, Anujit also being one of the dynamic members of it. Before it was, back to Niranjan, myself, Ayushi here. And we have the presenter and the monthly mentor. And for the last two meetings, we are now having an expert speaker as well, like Sidbhai today here with us to add his valuable inputs. And we have the MARIE format, which is the key for a neophyte where the method, assignment, and the assessment results, interpretation, and extrapolation are dealt in detail by step approach. And this is a team YOSI Journal Club, myself being in charge along with a dynamic team here. Niranjan is here today, Ayushi as well as Anujit is here. And if you are watching it on YouTube and if you want to participate in the YOSI Journal Club, you can WhatsApp us or mail us to the yosi.journalclub@gmail.com and you can be on the other side as well. It's an all-inclusive journal club, and you just need to fill out the Google Forms. And in case if you have missed out the previous episodes of our journal club, you can always scan this QR code and you can go back and see all the archives of our team and the previous team led by Anujit as well as Sonal ma'am. And just need to fill up this Google Forms as I told. If you're interested to come on the other side, we are an all-inclusive team and we would love to hear from you as well. So the history of Team YOSI and Team YOSI Journal Club is in 2021, we had 4 episodes of various subspecialties. In 2022, we had 5. And in 2023, you can see we had 7. And along with that, in 2023, we had our first IGO YOSI collaboration for biostatistics. And the numbers just kept increasing in 2024 when we took over. We had again another 6 capsules of IGO YOSI live wire. The topics again here for my dear friends and young ophthalmologists, we covered everything that is an untold story like case reports, photo essays, original articles, reference management and avoiding plagiarism, approaching rejection pragmatically, and mastering research in ophthalmology, RCTs, designs, and whatnot. And side by side, the subspecialty journal club was going. As you can see, we had 4 in 2024. And in 2025, we had one biostatistics webinar with IGO team. And we had 3 journal club webinars. In the last webinar, May, we had SK Rao sir as the keynote speaker. And today here we are for pressure from the posterior segment, as the dynamic JC team has coined. We have Dr. Siddharth Dixit sir to talk on the opening gambit, getting it right for a glaucoma patient after the journal club itself. So with that, I would like to call or introduce all the speakers as well as the my panelists for this day. And Siddharth sir is a very dear colleague and a friend and a brother as well. He's a consultant VST Center for Glaucoma Care LVP, and sir has numerous credentials to his credit, where his special interest is in angle closure glaucoma, lasers in glaucoma, MIGS, and surgical innovations. And some of the awards and honors are Best Poster Award, Best Poster Podium in GSI, AOS, and in the Dr. D.B. Chandra Disha Award for the Best Free Paper in Glaucoma, and very internationally acclaimed glaucoma surgeon, researcher, and a very avidly publisher as well as an innovator. Welcome, Sid sir, for being here today. We know such an auspicious day with the match simultaneously going on. Thank you for being here and taking your time. With that,
Thank
I'd
you.
like to thank you, bye. With that, I would like to call upon Dr. Niranjan to introduce the speaker for today, and after that, we'll have the monthly mentor.
Thank you, Prasanna sir. So we are delighted to have with us Dr. Tulika Bagaria. She is a first-year ophthalmology resident from the Nandadeep Eye Hospital. So she's done her MBBS from CCM Government Medical College and her internship at the District Hospital Durg. She's worked as a medical officer in government hospital and a multi-specialty hospital as well. She's joined as a DNB resident in the prestigious Nandadeep Eye Hospital, Sangli. Over to you, Dr. Tulika. Please go ahead and share your screen and go ahead with your presentation.
Thank you, sir. Good evening, everyone. I'm Dr. Tulika Bagaria, DNB first year resident from Nandadeep Eye Hospital, Sangli. First of all, I would like to thank YOSI for providing me this wonderful opportunity. Today's topic is slow coagulation transscleral cyclophotocoagulation for post-vitrectomy patient with silicon oil-induced glaucoma. This article was accepted on May 10th, 2021 and was published in September 21 in Journal of Glaucoma. Here are some of the abbreviations that I have used. So let's begin. As we all know, glaucoma is a common complication following vitreoretinal surgeries. Following PPV, scleral buckling combined with endophotocoagulation or silicon oil causes increase in IOP and it requires medical treatment. The persons which are not responding to the medical treatment need surgical interventions. We have two options for surgery, the conventional POP technique or the slow TSC-PC. Slow TSC-PC delivers fixed lower power of energy is given over long duration and it delivers photocoagulative energy to the ciliary body, which causes decreased risk of collateral damage surrounding the ciliary body and decreases inflammation. It is a retrospective study addressing clinical outcome of slow burn CWTC-PSC as a primary treatment for secondary glaucoma following PPV and SOI that is poorly controlled with medical treatment. Coming to the risk factors, pre-existing glaucoma, history of diabetes mellitus, aphakia, quantity of emulsified silicon oil, heavy tamponade agents. The aim of the study was to report the outcomes of slow coagulation continuous TSC-PC in patients with medically uncontrolled secondary glaucoma following pars plana vitrectomy and intravitreal silicon oil injection. It is a retrospective study performed in year 2015 to 2019 in Bascom Palmer Institute, Miami, Florida, which was approved by Institutional Review Board of University of Miami and adhered to Declaration of Helsinki. The inclusion criteria were 18 patients with more than age who developed medically uncontrolled secondary glaucoma attributed to prior SOI, regardless of glaucoma severity, preoperative and postoperative IOP, number of glaucoma medications, best corrected visual acuity, complications at week 1, 1st, 3rd, 6th, and 12 months post-op. Coming to the exclusion criteria, patients with glaucoma diagnosed before vitreoretinal surgery, post-operative follow period less than 1 year, previous incisional glaucoma surgery or cyclodestructive procedures, visual acuity of no light perceptions are excluded. The surgical technique, the retroberber anesthesia was given, G-probe was used, It was held perpendicular to sclera. Curved end of the foot plate was placed at limbus. Laser beam was directed 1.2 mm posteriorly towards ciliary process. Successive applications were made half width of G Pro foot plate apart, sparing 3 and 9 o'clock meridians because ciliary nerves and vessels are present over there. Balanced salt solution was used as a coupling agent. After the procedure, shield and patch were applied. Post-op prednisolone acetate drops were given for 3 weeks. Coming to the outcome measures, the primary outcome measure is the cumulative rate of a success rate at surgical success at 12 months. Failure was defined as IOP more than 21 mmHg and IOP reduced of 5 mmHg or less on 2 consecutive follow-ups or loss of light perception, and also reoperation for glaucoma. Secondary outcome measures include change in number of glaucoma medications, change in visual acuity, and post-operative complication. A point here to note is additional TSCPC treatment was not considered a glaucoma reoperation. Here is the statistical analysis. SPSS software version 25.0 was used. A paired t-test was used to compare IOP values. Wilcoxon signed rank test was used to compare pre-op and post-op glaucoma medications required. Kaplan-Meier survival analysis was used to determine the success rate. P-value of less than 0.05 was accepted as statistically significant. Here are the characteristics of study participants. Age group 25 to 74 years was taken. Follow-up duration was up to 12 months. Both male and female were taken into account. People were chosen irrespective of the type of glaucoma. Duration of SO endotamponade was 3 to 15 months. Talking about the results were discussed in terms of decrease in IOP, decrease in number of glaucoma medications used, and change in logMAR visual acuity. As we can see, there is no significant change in logMAR visual acuity. We can see that the IOP has decreased drastically from baseline values in 1 week and has remained almost constant till 12 months follow-up. The graph here shows the drop of IOP from 30 mmHg baseline value to 12 mmHg in 1 week and has remained constant of approx 14 mmHg till 12 months. The next graph shows number of medication decreased from 4 to 5 medications to 2 medication till 12 months follow-up, which accounts to about 52.8% success rate. 6 eyes were medication free at 12 months follow-up. The Kaplan-Meier plot shows here the success rate of 72% at 1 year. Of 18 patients, 5 patients met the failure criteria. Inadequate IOP reduction was most common cause of failure, occurred in 4 patients. 1 patient had reoperation, 1 patient had hypotony, and no patient had completely visual loss. Coming to post-operative complications, the post-operative complications that occurred have been highlighted. There was AC inflammation in 2 patients, CME occurred in 1 patient, hyphema was there, and hypotony was also there in 1 patient. Comparing the conventional POP technique with the slow coagulation TSCPC, it had reduced number of glaucoma medications, no significant change in visual acuity, no major complications were observed, but CME and hyphema were higher. Dewar et al. Study reported similar results showing incidence of iridocyclitis with slow coagulation TSCPC. Similar success rate was achieved by Ghazi et al. Study and Bloom et al. Study in success rate. Talking about the reduction in IOP, it was also comparable to other studies performed. Limitations stated in the article were that it is retrospective in nature, relatively small sample size was considered, lack of comparative group, long-term complication was not described. Coming to conclusion, study suggests the safety and efficacy of slow coagulation TSCPC in the management of glaucoma secondary to PPV SOI, repeatable, relatively easy, minimal invasive, rapidly progressive, less post-operative recovery period than more invasive surgery such as GDD. Surgical treatment of choice in refractory glaucoma in cases of vitreoretinal surgeries. Now, critically appraising the article by Mary protocol, it is a retrospective study which has a small sample size and has surgery determined by the same surgeon. Inclusion and exclusion criteria were well defined, statistical analysis were described, long-term follow-up was not noted, severity of glaucoma was not mentioned. A significant decrease in IOP, that is 44 to 53% was noticed, reduced number of glaucoma medications, no significant change in visual acuity. In addition, no major complications were observed. The success rate of the study was in decreasing the IOP was 72.2%. Slow coagulation TSCPC has comparable success rates as the conventional POP technique. Most of the complications were mild and transient. To extrapolate, comparative studies are needed to establish superiority of this technique over the conventional technique. To conclude, I would like to quote, in the silent battle within, glaucoma steals side, but the trend to fight remains. Thank you.
Thank you so much, Dr. Tulika. That was a very lucid presentation.
I would want to introduce the monthly mentor.
Yes, now we have Dr. Madhvi, who is the monthly mentor for this session.
Dr. Tulika, can you stop sharing your screen?
Yes, sir.
We would introduce the monthly mentor now. Aishi, over to you to introduce the monthly mentor.
Thank you, Dr. Prasanna. It's my pleasure today to introduce Dr. Madhvi Pillai, who's the clinical head of cataract and glaucoma at the Eye Foundation, Vellore in Tamil Nadu. She has done her MBBS from Kasturba Medical College and has finished her long-term fellowship in glaucoma at Arvind Eye Hospital, Tirunelveli. She has been also awarded travel grant for young ophthalmologists by the World Glaucoma Association in 2023 as well as 2025 and has several other awards to her credits, including Professor Yasuo Tano Travel Grant at APAO, Best Podium Poster Presentation at ACRS, International Heroes Award at AIOC and APAO. She was also the session chair for the instruction course in glaucoma surgery at APAO and also the instruction course speaker at ACRS 2024 as well as 2025. Additionally, she has been awarded several best video presentations and best papers in several conferences. She was also a finalist in Film Festival of Quality Teaching at ACRS both in 2024 as well as 2025 and is also the finalist of the prestigious Dr. B. Sridhar Rao Award at GSI in 2022 and 2024. Welcome on board, Dr. Madhvi. I would like for you to speak a few words about the article as well as the topic secondary glaucoma, which is silicone-induced.
Thank you, Dr. Ayushi, and thank you, YOSI, for giving me this opportunity. First, I would like to congratulate Dr. Tulika for such a wonderful presentation. So, she being a first-year resident, I feel she has done a wonderful job with the article. So, glaucoma secondary to vitreoretinal procedures, especially the silicone oil glaucoma, is one of the most difficult forms of glaucoma the glaucoma surgeons face. Usually, it is refractory to conventional medical therapy, and when it comes to trabeculectomy, the failure rates are high. So, we have now two favored options, that is the glaucoma drainage devices and the cyclophotocoagulation. So this particular paper focused on the slow wave cyclophotocoagulation. So why the slow wave photocoagulation? Because the conventional cyclophotocoagulation, the concern is that most of the times the destruction is so much, the hypotony, CME, and more importantly, the loss of vision. That is one of the most concerning factors about the conventional cyclophotocoagulation. So the slow wave photocoagulation, which uses a fixed low power energy with longer period, it is supposed to reduce the damage. So in this particular paper, the success rate is quite impressive with the 72.7%, and IOP reduction achieved was also 42%, which is also impressive, with a good anti-glaucoma medication reduction. So when we look at the literature, the success rate varies from 55 to 80%. Most of the papers actually talk about the conventional cyclophotocoagulation, and very few papers have slow wave photocoagulation. And another important point we should notice, there is a mix of cases most of the time, some after SOR, that is a silicone oil removal. But in this particular paper, all the patients had not undergone silicone oil removal. And another important highlight in this paper is the low rate of complications, and none of the patients had in fact lost vision. There were 3 eyes, however, which had decreased vision due to disease progression. That is, they had explained it due to the disease progression. Some of the cons of the paper, Dr. Tulika already explained. It is a retrospective study, and also it had a very small sample size. So apart from that, this is an interesting paper because it paves way for other modalities we can think about, like micropulse laser photocoagulation. Again, it's a less destructive procedure, and again, the literature is very limited, with some quoting 70, even 90% in cases of silicone oil glaucoma. And recently, the endoscopic cyclophotocoagulation can be explored, as it is more precise and it is done under direct visualization. Again, the data is limited, with only 60% success rate. And apart from that, when we consider GAT again has very limited literature in cases of silicone oil glaucoma, and the results are unpredictable, especially in these refractory cases secondary to silicone oil glaucoma. And I would like to invite the expert panel and Dr. Siddharth sir's comment as well. Thank you.
Thank you, Madhavi ma'am. Anujit, can you invite Dr. Akash A. Raut for sharing his valuable opinion and feedback?
Yes, of course, sir. I would like to introduce Dr. Akash K. Raut. He is a consultant vitreoretina UV and ROP specialist at Nandadeep Eye Hospital and PG Training Institute in Kolhapur. And he's completed his MBBS from BJ Medical College, and he's completed his residency in ophthalmology from the prestigious Guru Nanak Medical College, MAMC, and his senior residency from AIIMS Bhopal. He has a fellowship in vitreoretina UVA ROP from Sadguru Netra Chikitsalaya in Chitrakoot under the mentorship of Dr. Alok Sen. And to his credit, he has 12 plus PubMed Index publications and 20 plus scientific presentations, including Best Free Paper Awards at DOS as well as the World Ophthalmologic Congress. And his key areas of interest include diabetic vitrectomy, endophthalmitis, as well as ROP. Our second panelist for the evening is Dr. Varsha Belamji. She's completed her DOMS from MS Ramaiah Medical College, as well as a secondary DNB from Arvinda Hospital, Pondicherry, followed by a fellowship in glaucoma from Prabha Eye Clinic in Bangalore. She also has to her credit the FAICO in glaucoma and FAICO in cataract and phaco, and is the faculty and academic in charge of ESIC Medical College. She's working as a glaucoma and cataract consultant in Bangalore. And to her credit, she's been at the grand rounds and poster presentations at the World Glaucoma Congress in Rome in 2023 and has presented several papers and videos at APAO, AIOS, and other state conferences. I would like to invite both the panelists, Dr. Akash as well as Dr. Varsha, for their comments.
Thank you, Dr. Anujit, for the introduction.
Dr. Varsha, please go ahead.
Yeah, I said, so thank you for the introduction. I have, first of all, I'd like to congratulate Dr. Tulika for such a good presentation. Being a first year resident, and she's done a very good job. Few points which I'd like to mention was, as ma'am had mentioned, that all the patients who were studied, where they had silicone oil in situ. Silicone oil was not removed. So and so the efficacy of the procedure is something which we still have to think about. And it was a retrospective study from 2015 to 2019. And I think they could have followed up on the patients and then seen what is the current status now. That I would like to add.
Thank you, Dr. Varsha. Dr. Akash, do you have any comments from a veterinary surgeon's perspective?
Thank you, Yosi, for the opportunity and a very nice presentation, Dr. Tulika. Actually, from the retina's perspective, I want to say that early SOR has a role in the lowering the IOP. As the chamber is full of the silicone oil, there is no space for the movement of aqueous to and fro. But once the oil is emulsified, then the things changes, because the emulsified oil came into the AC, and there is a trabecular meshwork obstruction, as well as that become the multifactorial after the few months. So the early silicone oil removal as early as 1 month also tried. And recently randomized control trial has been occurred in the Chitrakoot itself, and they removed the silicone oil as early as 1 month, and there is no retinal detachment post silicone oil removal. So encouraging the retina surgeons or the retina specialists to remove the silicone oil as early as possible. And also one of the most important thing to say, that regarding not regarding this article, but informing patient to about go under SOR, because most of the retina patient don't know to go under. He has to go second surgery to remove the silicone oil. So the patient usually came after oil become emulsified and there is a loss of vision, and then things changes because of there is a glaucoma, silicone oil, emulsified silicone oil. So uh, early silicone oil, yes, removal, yes, there is a decrease in IOP. Definitely, there is a decrease in. I have one patient. I had just one patient a month ago where IOP is 50 post surgery 1 month. So I immediately removed the silicone oil. The IOP came down to 18 to 20 with just a single drug. So yes, definitely early removal as early as possible if there is no contraindication. So you have to go under the silicone oil removal.
Thank you for the wonderful input, Dr. Akash. Like, when should you call patients for silicone oil removal? Like, what is the average duration beyond which you think that there is a permanent damage?
Usually, within first 3 to 6 months, I usually remove silicone oil depending upon the patient. As early as I remove 2 to 3 months, but sometimes you have to keep the oil for a longer period. At that time, IOP is one of the most important thing to check. Other than silicone oil related optic toxicity also there, optic nerve toxicity also there. So you have to keep eye on that too. So as early as 1 month, just after the effect of a laser will come, and you can go with the silicone oil removal.
Thank you, Dr. Akash. Siddharth sir, your comments on the paper, sir, and your experience with this slow continuous wave transscleral CPC.
Right. So we are trying to move from evidence-based medicine to eminence-based medicine again. Now, I think now that we are into a JC, let us concentrate on what is the message that one should carry away from this article. Tulika, if you can put up your slides again with starting with the MARI analysis, it will help us. Now, one of the most important things that one needs to consider while taking a message from any study, whether it's a randomized control trial or an article, is to which patients do you apply it on? I am assuming Tulika is putting up the slides, right? So when you talk about the MARI analysis, and you go to assignment, you have mentioned that the inclusion and exclusion criteria are well defined. Well, the exclusion criteria seem to be well defined, but you don't know which patients were included, right? It is very clear that this may not be the only uh, surgery that was done for all these patients. Some patients with silicone and oil-induced glaucoma must have undergone SOR. Some may have had a glaucoma drainage implant. So you really don't know which patients were selected for this procedure. What you also don't know is why in these eyes the endotemp and tamponade duration was between 9 to 15 months. What was the indication for that? And could a silicone removal have been performed? Let us assume that it was essential to keep the oil. But was the oil emulsified in any of these eyes? We don't know that. So we do not know the inclusion criteria. We do not know which patients do we apply these criteria to. Okay. Now, when you go to the previous slide, the methods. Now, let's say, look, this is one of the first studies published on basically low slow photocoagulation, where you increase the duration, it reduce the energy. The micropulse does the opposite thing. It reduces the duration while keeping the energy the same. So basically, when the micropulse came, one thought of how we can use the present machine to still perform a safer TSCPC, and that is probably how this thing came into. Now, can you tell me, if you think that there is a patient ideal for this slow wave photocoagulation, how many burns are you going to apply? How many clock hours are you going to apply it over? So that information is missing. Now, retrospective study, okay, we understand you cannot give the indication everywhere, but the data which a surgeon does collect is the number of clock hours and the number of burns that has been subjected to TSCPC. That should have been shared. Let us move to the results. Right. Now, when you say no significant change in visual acuity, if you have 18 eyes on which you do cataract surgery on, and 3 of them lose 2 lines of vision, do you know what the confidence interval for this complication becomes? So I will explain it to you in a different way. So say a beginner cataract surgeon does 10 cataract surgeries with only 1 complication. Does it mean that the surgeon is going to perform 100 surgeries with 10 complications only? No, because there is a confidence interval when you go to larger numbers. And if you go to just websites and try to calculate this confidence intervals, the confidence interval, which is 1 by 6 now around 12%, can vary from 5 to 19%. And say I happen to be so unlucky that I become the person who gets that 19% patients losing vision by 2 lines. This is not something that is acceptable. And similar confidence intervals can be calculated for the one hypotony that they had. So if you extrapolate or do this procedure for 100 patients, you may get many more patients with hypotony, which should not have happened, especially with silicone oil in C2. And interpretation, again, when you say that slow coagulation TACPC has comparable success as conventional technique, you are going to extrapolation beyond data. The study has not produced data from its own patients, which will tell you that it is comparable. Now, when you go to extrapolation, that is where you look into the procedure in the light of present knowledge. And I would have been very happy if you would have quoted the 2 randomized controlled trials where low slow photocoagulation has been compared to traditional POP-based photocoagulation, and then it has been found comparable. So in my mind, in the short term, based on the 2 RCTs, it is comparable, but the long-term results, in my experience, don't seem to be that promising. So when you're looking at an article, be very clear about what is it that you need to look at, and not just look at papers that the authors have quoted. Of course, this paper came out in 2021. They could not have quoted a randomized controlled trial that took place or was published in 22 or 23. But as students of ophthalmology, we should go to that. All said, you presented very well. So these are not fault findings, but just an attempt to take you on a further and higher route in interpreting evidence. Thank you.
Dr. Siddharth, do we do this procedure at LVPI?
I I have done it quite a bit, especially when I was doing it in patients who have eyes with vision. Look, largely when we do TSCPC, we do it for painful blind eyes. But when I do it in patients with vision, I have tried this. And as I said, the long-term results were not very happy. The proper way to do a TSCPC would be to look or hear for a pop and then go 250 milliwatts below that pop. You don't want to listen to pops during a TSCPC because that basically means ciliary processes are bursting and you'll start getting complications related to that inflammation, whether it's hypotony, CME, uveitis, hyphema, all those things come up. And that is why you should avoid a pop. That's been the recommended textbook setting. Somehow, a lot of us don't do that. I don't know what the practice elsewhere is.
Thank you.
Sidbhai, thank you. Thank you for this wonderful, valuable inputs for this particular article. And without much delay, Niranjan, Ayushi, if there are no more comments from the panel, shall we move to sir's keynote talk as well?
Yes.
Surely, sir.
Yeah,
Yes.
any panelist, any other comments or something that you want to add?
So the specific gravity of the silicon oil was not mentioned. And also the mechanism, they were not clear, like what was the actual mechanism that causes silicon oil induced glaucoma. And as sir mentioned, whether the why was it why was the SOR not performed, that also was not clear. Few additions.
So these are your points for the author who has not mentioned it. Okay. In continuation with Dr. Madhavi ma'am and Siddharth sir, at least recently for the last 6 to 8 months, I've had an opportunity to use ECP, and during my tenure in Coimbatore, when I had the opportunity to use micropulse, I echo the similar sentiment that the results were still quite not fully predictable. We were not fully able to understand why. And certain patients did develop a good control, certain patients were not able to be controlled. And even suture gap for that matter, I performed 3-4 patients with the silicon oil glaucoma suture gap as well. My thought process was, if I do a suture gap, I would be able to get the angles open 360 degrees. So the filtration would occur at some plane, but it never works like that. Or at least in all the 3 or 4 patients I did, the surgery failed actually. So at least ECP, it's quite better with what I am seeing. I'm able to directly visualize and then do the blanching of the ciliary processes. Maybe more like slow, low CP, TSCPC. I think ECP is slightly helping out in that cause. Any of your experience or maybe even scientific evidence, Siddharth sir, ECP versus this slow transscleral CPC? Is it just the alternate effect, or?
I'm quite sure that ECP will work as good or better than the TSCPC or the slow wave CPC, because you are for sure blanching the ciliary processes, so you know that your energy is not going waste, and you are controlling the number of ciliary processes that you are blanching quite well. So it should work as well, in fact, a little better. But one has to remember that it is an intraocular procedure and it is not completely free of dangers. And one should not forget that people can get hypotony, cyclitic membranes, and persistent uveitis even after endo-CPC.
Thank you, Siddharth sir. I think thank you for all the pertinent points. Even one of the points that you mentioned, one patient developing hypotony in 18 and suggesting the confidence interval for all the young ophthalmologists, especially when the sample size is minimal, full of confidence interval. All these things plays a lot when you structure your methodology for research. So with that, again, I would like to call upon Siddharth sir himself for his keynote lecture.
To add, Prasanna sir?
Yeah, you have something more to add?
Yes, sir. So
Yeah,
about the
please, please.
suture GAT,
Yeah.
since we are talking about silicone oil-induced glaucoma, and I feel the oil, emulsified oil particles would have already gone into the trabecular passages and blocked the trabecular outflow. So will doing a suture GAT really help? Because we're only opening up the pathway, but the drainage channels are already blocked. So I think, I mean, will it really serve the purpose?
Yeah, that's what I thought. See, what I cognitively thought was it should work because I'm trying to open it up.
Remove, yeah,
I have
whatever
a-
part
I
of
have,
the.
I have a good image also. Maybe I'll share it at the end. I'll get it ready.
Yes.
So
Yes,
after
sir.
I did the suture GAT for first 2 or 3 days, I felt the IOP to be slightly controlled, slightly, ever so slightly, and the
Okay.
globule started going and depositing in the tract very nicely. Even
Okay.
inferior part, once the oil gets emulsified, I thought immediately I will get lucky. But even in the inferior part also, I was able to see emulsified oil getting deposited. And when I was discussing with my colleagues also, people felt in suture GAT in silicone oil. I have very few numbers, but at least Siddharth sir or Dr. Madhavi, who was part of the Arvind team, I think at least in my hands, I felt it was not working.
Actually, when we look at the evidence, Dr. Varsha, there are two papers which describe suture GAT and silicone oil glaucoma. But again, the success rate, if you see, again, those two papers also had very less patients. One of the papers had just 15 patients and another had, I think, it was a mixed case scenario, secondary glaucoma, they said, and 8 patients, I think, as far as I remember. And the complete success was around 26.7%. So they needed at the end of the paper, the most of the patients were on medications by the end of the study. So the results were really even going beyond evidence, practically when we were doing also, the results were quite unpredictable. Some patients it was working well beyond evidence in the practical
So
case
what's the
scenarios.
procedure of choice, ma'am, in silicone oil-induced glaucoma patients?
I think we should put that question I was supposed to ask Siddharth sir.
Yeah, so basically, look, silicone oil-induced glaucoma, you broadly, when you're making a decision, have to classify into those with emulsified particles in the anterior chamber versus those who have had an SOR, and for compared to those who will never be able to get silicone oil out of their eye. So patients who have emulsified oil, transscleral cyclophotocoagulation by or photocoagulation, cyclophotocoagulation by whatever modality you can do is the only option. Because if you place an implant or do a trab, ultimately the bubbles will find a way into the subconjunctival space and fibrose everything. I would not recommend GAT for patients who have silicone oil bubbles because one, they will block, they might go and block the collector channels and they will, by capillary action, be drawn towards these collector channels and will block them. And the worst thing that I am scared of is a bubble going into the circulation and causing an embolism. Silicone oil particles have been reported in the cerebral circulation after injection into the eye. So this is not too far-fetched. Nobody will probably correlate this. And so, but probably nobody will come with a legal case against you, but plausibly, this is a possibility. Now, if the silicone oil is quite okay in the sense that you have an intact bubble, high density oil, and you're careful enough to follow up the patient and ready to exchange it at the first go, I would go with an implant in the inferotemporal area. And a valved implant, not a non-valved implant, because hypotony can push the silicone oil into kind of situation where you get emulsification and the oil bubble coming into the anterior chamber.
As we speak, as you rightly pointed out, so this was one of my cases where there was an emulsified oil and it was not actually in the angle. It was slightly settling somewhere between the parapupillary area. Post silicone oil, so this was a suture GAT case which I did, and things went well. The suture 360-degree, it was a small, short suture, but I was able to complete the GAT 360-degree, and things looked like it went well. I was able to complete it in the subincisional area. And post-operative, this was what I was able to document in 1 month. This picture was not there. I don't have the pre-operative gonio picture, but definitely the oil were not there in the particular quadrant pre-operatively, this crowding. So maybe the capillary action that you rightly pointed out, it had an ability to suck the emulsified oil into it. And I think, as you rightly said, from an ethical boundary as well as patient's point of view, you never know that it may get into the circulation as well. Yeah.
Right. And we have to remember that all these Schlemm's canal MIGs, they don't do well in three conditions. One, if it's of a prolonged duration, if you get very high IOP spikes, and if there is inflammation along with it. All of these three can happen with silicone oil-induced glaucoma. So if we want to do a Schlemm's canal-based procedure, we should do it really early in the course rather than wait for spikes to not respond to multiple. So that way, with our keratoplasty colleagues, we just go in and do a very early GAT rather than wait, and that gives very good results.
Any questions or any comments by any of the panel?
Sir, in our center, we usually wait for 6 months and we combine the SOR with the glaucoma drainage device. Usually it's an Ahmed glaucoma valve. And till now, what I have seen is they are okay. I mean, either they will develop complications related to the valve or they're on 1 or 2 medications. Like in my 6 months follow-up till now, among the 6 procedures what I have done, I think I've had okay success till now. But long term, we have to see.
Right.
What I have seen, sir, is most of them they go into this hypertensive phase very early. Whether it's is it because of the procedure when compared to other valve surgeries, like for other indications compared to silicone oil induced, I have seen the hypertensive phase being more common here. Is there any correlation, sir?
Yeah, so probably some bubble, some amount of silicone oil related chemicals, they just go into the subconjunctival space and cause this. So it's never the best, the ideal option, but probably the best option to do an inferior temporal implant.
Okay. Okay, sir.
Thank you. Thank you, panel. I think, Sidbhai, we'll go to your keynote lecture. I think the topic is very interesting and we don't want to go back. Maybe at the end, we'll take up some more questions.
Right, I had planned to start first, shoot overtime, and then restrict the JC to 20 minutes. It's become the reverse. I will move a little fast and skip a few things. This talk is specially for the postgraduate students, and I am talking about how do you start treatment of a patient who comes to you naive of treatment and you are the first doctor treating that patient, and a few things that you should be careful about and things that you can take care of. I will also focus a lot on history and examination. Starting with that, it is very, very important that we ask about all the possible signs and symptoms of glaucoma, specifically probe and ask them if they had any of these symptoms. Though 95-96% of patients will not complain of any of the other things other than gradual decrease in vision, but do have pointed questions for your patients. Also, past ocular history. Remember that not all steroid drops are white in color. Most commonly, patients use a combination of steroid and antibiotic for allergies, which they take up from the pharmacy. And these are not white in color typically. They are just like any other liquid. And when you ask about a family history of glaucoma, you have to establish the degree of the relation, whether it's a first degree relative or a second degree, and find out how the course of glaucoma had been for them. A patient whose parent became blind at 40 years of age versus someone who lived happily with 2 drops till 95 they have different history of two different kinds of glaucoma. So not only asking whether anybody had glaucoma or not, but also very important to find out how severe the glaucoma were in the relatives. Systemic diseases are very important, especially if you think that the treatment will interfere with the systemic disease, or if the disease had been treated with steroids. One thing that we have realized of late is the importance of stop bank questionnaire for patients with sleep apnea. So this is a questionnaire that is available everywhere. And these are questions that must be asked to every glaucoma patient, because we're finding more and more patients, especially those with query normal tension glaucoma, being affected by sleep apnea. And then if you find these positive, go ahead with the examination or objective measures for sleep apnea. And once you get a score of 5 or more, evaluate them with polysomnography. Certain habits which are very common in our patients, like doing a lot of breathing exercises and especially drinking large quantities of water getting up in the morning, can be big confounding factors in patients with glaucoma, causing progression of normal looking IOPs. It is also very, very important to perform a very careful examination at the first go. And I'm very certain that very few patients get an early change in diagnosis after being diagnosed to have something like POAG or a normal tension glaucoma. It happens only after many, many visits that you suddenly see a synechia and call it angle closure. You see a speck of pseudo exfoliation or a pigment which is suggestive of an old KP. So the first examination and the first instance when you're taking a history is the most important occasion for an ophthalmologist to make a diagnosis. I will just give you certain examples of how you can easily miss very, very important findings. Now, it is very important to carefully look for the endothelium or deposits on the endothelium. There may be KPs. Here you see a typical spindle-shaped deposit of Krukenberg spindle. Here you see a very strange kind of pattern of deposit of large globules of pigment, and this patient had a developmental anomaly. Now, do you find anything abnormal in this pupil when you look at a global picture or a large picture, a small picture in low magnification? But if you carefully look at the shape of the pupil, in this area, it doesn't look round. And when you go magnify it, you find there is an atrophy of the pupillary rough and an atrophy of the particular segment of the iris, telling you that this is a iris whirling that is typically seen in patients with primary angle closure and primary angle closure glaucoma. So if you see an occludable angle in presence of this iris change, it becomes PAC and it becomes eligible for performing a PI. Again, this patient did not have any pseudo exfoliation deposit on the pupil, and only when the pupil was well dilated did we see this pseudo exfoliation on the lens, and then notice that there was a frank deposit of pseudo exfoliation on the endothelium. So do not go with your 68, 60, 78D or an indirect to perform the fundus examination immediately after dilatation. A lot of findings like this and pigment dispersion can be caught only when you perform a slit lamp examination after dilatation. And what is this? Again, a patient where there is only atrophy of the pupillary rough, sphincter atrophy, no pseudoexfoliation. But when you look at the dilated examination, you see these radial pigmented lines, which by many are considered as pigmentary PXF and a precursor to pseudoexfoliation. Now you will wonder what this eye is. Now this eye was examined after dilatation, and there was nothing abnormal on the posterior capsule. Why was I looking for something in the posterior capsule? Because this was a patient who had a Krukenberg spindle. You can see that hint of that. Only when I performed a gonioscopy, I could see this peripheral pigmented line deposited at the equator. And if I had not specifically looked for it, I would have missed it. And this is again something that you probably need to go to certain extremes to catch these findings. We all know that gonioscopy needs to be performed in a completely dark room, right? Gonioscopy always has to be performed in a dark room, but that statement is not correct. It has also to be performed in a bright room in order to differentiate between a normal looking ciliary body band in an eye not affected by trauma, in order to differentiate it from a eye with angle recession, and to study various other features like NVI or a cleft. You need a bright illumination. So you need to perform gonioscopy to begin with in the dark, but also in bright illumination to study the nature and the greatest depth of the angle. We very often forget that while gonioscopy, we remember that needs to be performed in the dark. We very often forget that Van Herrick's also needs to be performed in the dark because pupil constrict. And when you look at the eye in the dark, the peripheral iris can get crowded and show you how the angle is shallow in the periphery. Now, what have we dilated the patient for? We have dilated the patient for a dilated examination. And then we pick up a lens and look at the disc because we are in the glaucoma clinic. We forget to look at other things. And we appreciate the disc best when you are at quite a good magnification and looking purely at the disc in a stereoscopic manner. But remember that the fundus also needs to be evaluated while you are zoomed out to catch that nerve fiber layer defect, which you will miss if you look at the disc alone and not at the fundus, especially if you don't go with a green light or the red free light. You may miss not only a nerve fiber layer defect, but also a disc hemorrhage. Now, what investigations do you need to perform? If you have ability to perform only one investigation, please go for a visual field. But if you want to add one more, it can be either an optic disc photograph or the OCT. OCT is preferred for a glaucoma till certain extent. Advanced glaucomas, you should not be doing ACT. The moment the thickness of the RNFL goes below 60, just dump OCT and move to optic disc photographs for structural documentation of the optic disc. The visual field, once you have performed, look at these two GPAs. On the left-hand side, you have a GPA where the baseline is solid. Of course, this patient never came back. And if you look at this, coincides with the COVID period, but has good baseline, which will give you good opportunity for comparison between visits compared to this patient where there is a progression. So, well, this is not a real progression, but you need to have two baselines which are very close to each other in time distance and very similar to each other in severity in order to have a good baseline. Also, though we do not have multiple IOPs very often before we start the treatment, but if you find an IOP normal at baseline, if the IOP is disproportionate to the disc damage, like IOP is 22 and you see a very advanced glaucoma, if you know that the eye has pathologies which are known to have spikes like angle closure, juvenile open angle glaucoma, pseudoexfoliation glaucoma, steroid-induced glaucoma, Posner-Strassman syndrome, do not hesitate in performing a diurnal before starting treatment because you are very likely to catch a spike if you pay attention. Now, what do you do when you see a patient with glaucoma? This is a typical patient with moderately raised IOP, inferior disc damage, superior field change. And what do you do then? You start the patient on one drug or two drugs or three drugs. I very often get an argument that the pressure is not low, it is quite high, 28, and a 30% reduction from this will still end up in a pressure of 21, which may not be sufficient for this patient. But we forget one thing, that all drugs, and especially PG analogs, they bring about more reduction in intraocular pressure with a higher baseline IOP. And this has been shown to be true in trial after trial, that compared to 24, if you start at 34, the PG analog may show an IOP reduction greater than thus 30 to 33%. And so until unless there's a big danger, like what you see in advanced glaucomas, always start with a monotherapy. Cover the patient with, say, acetazolamide once or twice daily till 48 hours before you see them if you are worried. But definitely start with monotherapy before jumping onto the second drug. Now, what makes you choose your monotherapy? Why, whether you will start with just the percentage efficacy or something more? So percentage efficacy, PG analogs are the best, very little to differentiate between them. But if you look at the difference between the peak and trough, the timolol follows second in the trough versus peak action after the PG analogs, followed by other drugs. And if you look at the worst possible action or the maximum reduction during the trough, the alpha agonist and topical carbonic anhydrase don't do that well. Apart from that, the nocturnal control is best with PG analogs. So my choice of treatment is this as the first, second, and third line drugs. The latanoprosin, whenever we get it, will probably be somewhere between PG analogs and beta blockers. Rho kinase inhibitors, given with the redness that they cause, rank below beta blockers for me. But of course, you have to look at other risk factors. Now, if the same parameters were present in a patient with much more advanced glaucoma, here I would not hesitate in starting 2 drugs. You will not be wrong if you start this patient on 2 drugs and watch this patient early. What is more important is that if you see this patient where you started 1 PG analog and 2 weeks later the pressure has become 21, what should you do? After all, the European Glaucoma Society guidelines say that if the reduction is not sufficient, you should replace or at least add another agent. One has to remember that the PG analogs and most anti-glaucoma medications, they will take 4 to 6 weeks to act properly. So wait and not hastily add another drug. Whatever drug you start the patient on within the first few months of therapy, they are never going to reduce to a level below that. So be very careful whatever you are subjecting the patient to, because that treatment the patient will carry on for life. And one cannot but stress enough the multiple side effects systemically that you can have. I will not go through this list, but this is just an attempt to demonstrate the amount of side effects that different agents can have on different systems, some of which we think as very important, some of which, like depression and decreased libido, we don't think are important, but these are all very, very important things to consider, looking at the age group and the risk profile of the patient. And never, ever leave a glaucoma patient to use medications without telling them to occlude both the punctums, puncta, for around 3 to 5 minutes after instilling each glaucoma medication. That can be a game changer and lifesaver for a lot of patients. Pregnancy is a special condition, and you can find my article free on the internet if you look for it. And I will not go into it, but patients who are in the childbearing age are trying to become pregnant, undergoing IVF or have been recently married, do tell them that they need to come back to you the moment they come to know that they are pregnant. And not to forget, we always keep looking at the eye, right? So we should not forget that the glaucoma medications can cause a lot of side effects in the eye. These are patients who have SPKs on the cornea. And if you stain and examine the patient properly, you will find them on the conjunctiva too. And these are usually related to the preservative. You can see diffuse congestion and chemosis. This is usually related to molecule, but can also be to the preservative. This is contact dermatitis. And if you see it on the lateral canthus and surrounding area, what does that mean? It means that the patient puts the drop while the patient is lying down. Because if the patient puts it while they are sitting, it will be in the medial canthus area. This is a gross allergy with papillae in the upper tarsal and the lower tarsal conjunctiva. And this is usually with the molecule. And this is an extreme example of surface toxicity where you see loss of limbal stem cells, synechiae in the symblepharon in the fornices. And this is basically gone into the OCP and drug-induced pseudoempiphoid category. Never let a patient reach this stage. Also remember that while the molecule and the preservative may be same in every drop, more than 98% of the volume is formed by the excipients, which the company can decide and doesn't necessarily have to declare out to you. So choose good companies with strong reputation and commitment to glaucoma care. One of the ways you can reduce the toxicity to medications is by combining medications. And these are the two commonest ways in which I combine medications. Using a PG analog at night. I don't want to use PG analog in the morning because there are animal studies which have shown greater efficacy of the PG analog when used at night. And I don't want to use timolol at night because it works the least when you instill it with the aqueous secretion rate being the lowest. Another common combination that I used is that of a PG analog, ripacidil with timolol, and brinzolamide with brimonidine. The timolol, when used with ripacidil, counters the congestion very significantly because it has a vasoconstrictive effect and can help you increase the tolerance and acceptability of the patient. I will end up with one situation that I faced around 10 years back. And this lady came to me a month back with a gap of 10 years and she was still doing well. Now, this lady had a YAG PI around 6-7 years before the presentation and was on 2 PG analogs. I don't know why, but was on 2 PG analogs. And she had a shallow anterior chamber still, a patent PI, good visual acuity, but a very high intraocular pressure in the left eye. And the angle in the left eye was closed. In the right eye, I was able to open the angle in one quadrant and I saw sine wave sign there. And I was at a clinic where I could not have administered mannitol. So what did I do? I give the patient pilocarpine, 1 drop, 2 tablets of Diamox. And can you imagine what happened after 45 minutes? The pressure came down from 42 to 11. So this was a patient with plateau iris syndrome who on pilocarpine alone did very well, did not come to me for 10 years and was still doing well. So establish a solid baseline, start low and slow like the article mentioned here. Above all, cause no harm, know your patient beyond the eye, care for the eye and the ocular surface, and do not forget that the cheapest drug, pilocarpine, can sometimes work better than the PG analogs if you can catch a patient with plateau iris. Thank you so much.
Thank you so much, Dr. Siddharth. Do we have any questions for Dr. Siddharth?
I have a question for Prasanna. What is the score?
117 for 3, sir. Yeah. Anyway, Sidbhai, really,
Dr. Siddharth, I have a question.
thank you,
Yeah.
Sidbhai, for being here. Of course, Ayushi is having something to ask. All the images, all the small points that you added to add a beta blocker with a ripasudil, or even to show the gonioscopy for our young ophthalmologists out there. The darkroom examination is always what we elicit, but showing them how you need to have it examined in a photopic condition as well. And it was really very captivating, Sidbhai, and it's going to be there in our YouTube archive. And it's a testimony, Sidbhai, that we started with 60 participants and the attendees are still 46. Today, it's a big number, whatever said and done. And especially for today, people have all turned up in good numbers, and still we are having 46 participants. That shows the quality of discussion as well as the keynote speaker has brought on to the plate. With that, Ayushi, you wanted to ask something to sir.
Yeah, the patient of contact dermatitis that you showed, did he also have prostaglandin associated periorbitopathy? It seemed like.
No, the patient was on a combination of brimonidine and timolol only. So probably
Okay.
that what you saw was age related. I may be wrong because you are a better expert at picking things up related to orbitopathy.
Okay, thank you.
Sidbhai, even that patient which you mentioned on a lying down position, it is like very evident that that is the mistake there, or could it be because of the attender's mistake, or putting an excessive.
No, so this was a very old. He is a very old man, and this is one patient I have performed surgery on, despite him being controlled on just 3 medications because of the allergies that he had. He's into his 80s now, and he was just unable to instill the drops properly. And he would lie down, use what techniques. He just could not instill the drop in his eye while sitting.
And he was
So,
himself dependent on himself to put the drops.
yes.
Okay. Any questions or to sir, or any comments from our panelists, or any questions? Madhavi ma'am, Dr. Varsha.
So that was a wonderful presentation. So many beautiful clinical images. Just had a question that progression analysis you were showing, 2 images you had shown, right?
Yes.
So in that, the second one also did not have 2 baseline. The second one on the right side.
No, the baseline in the GPA printout will always be 2. What?
But it was not close to each other, I think, if I'm not wrong.
No, I tried to fool, but I thought I will get away with it. So I'll actually show you the image. I just picked up an image to show you how the baseline is different. So if you look, this is June 2, 2017 and June 28, 2017. I should have hidden this. But what you see here is a
Sidbhai,
change between the 2 baselines.
we are not able to see the screen. You are sharing it, Sidbhai.
Oh, sorry.
Yeah.
Yeah. So what you see here, this is also performed close after the first baseline, most probably because the field did not correlate with the first one. And there is a progression in the right eye. In the left eye, the baseline is relatively more stable. And in fact, this is the right and left eye of the same patient.
Same patient, okay.
Yeah, so I just tried to use a cheat code, but you caught me. Basically, the 2 baselines should be similar.
Yeah. Just had a doubt, sir. Thank you, sir. Thank you so much.
Any questions from any panel, any of our YOSI members? If not, I think we have held sir for more than 1.5 hours now. I think sir joined 15 minutes prior to the talk also. And thank you, sir, for really taking your time, and what masterclass we had today. I think it's going to go a long way in our archive, and the YouTube views are there for people to see. With that, we have this traditional custom in YOSI Sidbai. We give them the certificate virtually and then post it in the group. So, Dr. Tulika, you are here with us yet? Yeah, Dr. Tulika, best wishes for your wonderful presentation, and thank you for volunteering and taking the tough job. And I would like to hand over the other certificates to my team as well. Niranjan is here, Ayushi is here, Anujit. So each one of you can hand one certificate to the presenters of today. And I think today is again, each one have taken their special time to be here. Niranjan, over to you.
Thank you, sir. So it is indeed my privilege to thank Dr. Madhavi R. Pillai for her valuable time and participation as the monthly mentor in this edition of YOSI Journal Club held on the 3rd of June 2025. Thank you, ma'am. And it is in fact my privilege and honor to thank Dr. Siddharth Dixit, sir. So, sir, if there was the best way of concisely explaining glaucoma in an overview, there could be nothing better than today's lecture, sir. Thank you so much. And it is indeed something that will be archived in our YouTube, and it will be available for the benefit of all the young ophthalmologists across the country. So thank you, sir, for being the keynote speaker in today's webinar held on June 3rd, 2025. And over to Dr. Ayushi to felicitate the panelists.
Thank you, Dr. Niranjan. I want to thank Dr. Akash. He was the only posterior segment person in the house and for sharing his inputs. I also want to thank Dr. Varsha for her wonderful insights on the article as well as on the topic.
Yeah, and of course, we are
And
the
of course, Dr. Prasanna.
yeah, we are the team, myself, Ayushi, Niranjan. Anujit, a few words from you. Anujit is one of our one of the founding members. I should say he's been there for a long time. And Anujit, you can share the for our members, if they want to be on this side, what is that they have to do? Yeah.
No, sir, thank you so much. Journal Club has really evolved over the years, and I'm really happy to see us being guided by stalwarts like Siddharth sir. I think the way he's explained and described and lucidly broken down it for a postgraduate, it's how we read it or how we should read it from textbooks like Schaffer and Shields. I think he's totally taken the essence out of it. Even the entire guidelines, I still remember all the flowcharts during my residency when I read it. And when he revised those flowcharts, I remember that, okay, maybe I read the right things, because it's continuously being revisited again and again years down the line since when it was initially brought up. And we've always been a very closely knit family here at YOSI, and we always invite everyone to join us at Journal Club, because no matter what, we do learn a lot. So if anyone is watching this even later on, please get in touch with any one of us or write to us directly. I think that ends it for the evening. We can just, if anyone is listening, if I will just take a screenshot. So if everyone can just put up the YOSI peace sign, and I'll just take a small screenshot. Dr. Akash, yes, we have everyone. Smile. Right. Thank you, everyone.
Yeah, Anuji, just two more people. So one is our Numerotech team who's helping us with the technological seamless partnership, and another one is Microlabs Abhijit Sanyal and his team. So for the first 3 years, we were running mainly without much sponsorships, but then this event is brought to you all by Microlabs. And Abhijit sir, if you are around, do you want to share your experience?
Available. Sir, your words before we wind up for today.
Yeah.
Sorry, I have a very bad throat, so I'm trying to make. I think it's been wonderful opportunity, and thanks to our keynote speaker Siddharth sir for accepting the invitation from YOSI and all our case presentation mentors today. We are happy to be part of it, and we try to progress from one program to next program, and that is our endeavor. Thank you so much.
Thank you so much, Abhijit sir. Thank you for being there with us through the entire session. Over to Sir.
Yeah, Niranjan, closing statement by you, and we'll go off maybe. Yeah.
Okay. So on closing remarks, I thank the entire team who has joined us And at the outset, again, thanking the keynote speaker, Dr. Siddharth sir, the panelists, Dr. Akash, Dr. Varsha, the presenter, Dr. Tulika, and the monthly mentor for today, Dr. Madhavi, for sparing your valuable time and being here with us. So until next time, have a good night, and let's get back to our more important job of the IPL. All those,
Thank you. Thank you.
Thank you, everyone.
Thank you. Thank you.
Thank you.
Hi, sir. We can go off live. Thank you, Madhavi ma'am. Thank you, Dr. Varsha.
Thank you. Thank you.